patient teaching handout for medications. It's just so it's easier reading with medications. I don't know if it'll help you or not. It's not anything, it's like when you do patient teaching and print out material, sometimes it's written on a different level, more understandable. All right, since I have, what?
Can you do this for all of them?
What's on your map?
But it doesn't,
Is it?
Is everything on?
Or is it from your lectures?
No, it's the antipsychotics are in there. I just do the anxiety lecture. This has some meds, but it overlaps.
Okay.
A lot of these meds will overlap. And a lot of times they like to use anti-seizure meds or stuff, so.
I have a question in regards to medicine. So when it comes to us knowing them, what is the most important part about it? Like for us to make sure, I mean, because it's obviously going to be hard to remember everything about all medications.
Well, you're gonna have to know, the mechanism of action, side effects, it interacts with stuff. Are you gonna know every little thing about it? Or what do you need to do before you give it? Like, if there's labs you need to be assessing, you need to know the labs. If there is a level that needs to be drawn, you need to know, what that level and what it would look like. Like, you're gonna get with mood disorders, lithium, the different levels and what it looks like when they're toxic. What else? An evaluation, that's real big too. Like the whole nursing process is related to the medication. Are you gonna know every little bit of the side effects? You know the big things, a lot of them cause nausea and stuff like that. You're new to this, I would just get used to looking at this stuff. ATI breaks it down nicely. I usually go over in lecture what I expect you to know for the test. So, but I'm not, see, our tests you have the NCLEX at the end, right? So I don't know what they're gonna ask you. So just the way you, the whole nursing process, you put it towards the med, like, why are they getting it? So if you look at the pathway, that'll lead you to the treatment, and that's, the mechanism of action, what it works on. And that's with all, like, med-surg, mental health. I know, it's a lot. You look at the group, and then, if you look at the group of it, like, there's, the different types, like, of SSRIs, if there's, like, they all have similar side effects, but one may be a little different, you know what I mean? So, you know it as a group, and then you know the one that has some differences, if that makes any sense.
Thank you.
All right, I don't know, it's probably more overwhelming when I explain it, right?
No.
When you write up the med template, see what it's asking you for,
Well, it's funny because the ATI book loves a bunch of them in the same category, and then they're all the same except for like it will say risperidol does this,
Right.
That's the only difference. The rest of them it says it basically.
And you have the Adams Farm book too, which can.
And I use Nursing Central. I look each up on Nursing Central to get some differences, but I just thought it was.
And Adam, he talks about, I think, in relation to Batho, so it might make more sense. Oh, for goodness sake. All right. Sorry about that. Oh, look who it is. Welcome.
What do you think I wasn't coming?
No, we were actually waiting for you. No, I got signed out again. All right, so let's get started on this, and, all right. today, we're gonna talk about eating disorders. The learning outcome, we'll be able to discuss the impact of society and culture on the development of eating disorders, identify the signs and symptoms of anorexia nervosa, bulimia nervosa, and binge eating disorder. We're gonna identify 3 realistic outcome criteria for a patient with an eating disorder, understand the multimodal approach to the treatment of an eating disorder, and organize care based on the nursing process. So we'll just get a little bit into, not much, a little bit into, so we'll talk about the hypothalamus. That it regulates the appetite, and it recognizes when somebody feels full or not, or satiated. One of the things is everybody needs nutrition to sustain life. You learned about, everybody here took a nutrition course and how important it is, for a lot of different things. Skin, healing. Eating is more of a social thing and a cultural thing. A lot of times, who here goes out to eat with their friends? Who here invites people over? Who here has family dinner? So, a lot of American culture is based around eating, and society influences the way people look at their body. So an example of that would be a model. Now, more current, they're using all different size models, but for the longest time, it was the size 0, 6 foot tall. But now, people are more accepting of different body types and how cultural looks at a body. Different cultures view eating and weight. They all have different values on it. So when we talk about anorexia, it accounts for 1% among young women. It usually is females between the ages of 12 to 30 years old. Doesn't mean it doesn't happen before, doesn't mean it doesn't happen afterwards. It's less common in males, but it's about 10%. So they always talk about, then with sports and wrestling and they need to make a weight, they might be more apt to anorexia. Bulimia nervosa, we're going to get into the differences of all these in about a minute. Some of you are probably already aware of it. This is about 4% of young women, usually late adolescence to early adulthood. And this is common in societies that emphasize fitness. The difference is they're either slightly under or slightly overweight. They're not more underweight or more overweight. So obesity. So obesity is not really a psychiatric disorder. However, binge eating disorder, which is associated with obesity, is. So obesity is, we all know what a BMI is, right?
Yes.
Okay, so it's a body mass index of 30 or more. So usually, so in America, 69% of the people are overweight. Of that number, 35% are obese. So obesity is not the psychiatric disorder or in the DSM, it is binge eating. So anorexia. So anorexia refers to a prolonged loss of appetite. Usually there's a restriction on the intake. It's usually significantly low, some as low as 200 calories per day. There is also an intense fear of gaining weight, even though their weight is low, they don't perceive it that way. There is what's called a disturbed body image. So they don't see themselves for how they really are. And it's their perception of being fat when, I hate to use that word, but that's the word you're going to use, when they are either excessively thin or underweight. There's 2 types. The restricted type, which restricts calories, or the binge eating purging type. Do you know what purging is? Doing stuff to get rid of food. So with the assessment part, The anorexic, it will be afraid of being obese. They will grossly distort their body image, so they perceive themselves as being a different size, so treating them, you have to remember that. They're gonna be preoccupied with food, they may be talking about it, they may spend a lot of time fixing it, but they refuse to eat. An individual may present, weighing less than 85% of their, expected weight. Some of the complications related to anorexia is amenorrhea, do you know what that is?
Not,
Absence of menstruation. They may present with dehydration, where they're not getting enough fluid intake. We know that nutrition will affect the skin, the hair, so you'll start seeing dry skin, hair loss, brittle hair. If they're not eating right, they may be more sensitive to cold. They'll have, do you know what Langu is?
Like baby hairs.
The little thin baby hairs on the face, and it's those dark hairs. Do you know what that is?
peach fuzz?
No, it's like the dark, sometimes when a baby's born, they have this dark hair on them, and it usually falls out, but somebody who is not getting adequate nutrition will present that way. They might have it on the back, their arms, and their face. So they could have a slow or irregular heart rate. So remember, if you're not getting your nutrients, it's going to affect your electrolytes. You didn't really get into cardiac yet, but it's going to lead to cardiac dysrhythmias. That can lead to them to death, to cardiac arrest. You learned about your electrolytes, and you learned about how, they need to be at a certain number. So here they might not have enough, or they might, it's not balanced. So because they have deficient fluid volume, they're gonna be hypotensive, you might see dizziness, they might have tingling in the hands or feet, they're bruising easily. A lot of times if they're using diuretics or laxatives, they may present with edema. Do you know what edema is?
Fluid on earth.
Decreased bowel motility or constipation. So, because it's slowing down. Yeah, peristalsis, thank you. Sometimes my long days, that's like I'm having a stroke, and I'm always like this. Just think about somebody who's not nutritionally sound. What are they gonna look like? If it's messing with their electrolytes, it's gonna affect their kidneys. It could lead to kidney failure, weakness, and fatigue. They're not getting their nutrients, so their bone density is gonna be affected. It can affect their liver. So, but here's the key, anorexia is very dangerous. It's the dangerous of the most because of not getting enough nutrients. So it could lead to death. Some of the other complications, you know what hypokalemia is?
It's a low calcium.
Right, thrombocytopenia, did you get that yet?
Combo.
So they have an increased risk for bleeding with that, right? Why don't we pull out our nursing central, because I know you like it. You don't have one? I'm used to everyone having all this before. It's okay though. High cholesterol, elevated BUN, what's BUN for? Kidney, right? We just talked about that. Elevated carotene levels, I guess it's related to diet. EKG changes, you didn't get cardiac, but at the end of the heart beat is the QT interval, which a lot of times, which I talk about, when you take medication, it could prolong, which could cause them to have a cardiac arrest because when the heart's resting, it goes into the heartbeat. Metabolic acidosis from using laxatives. Too much vomiting will cause metabolic alkalosis, the blood sugar will be abnormal, and it could cause anemia, leukopenia, and lymphocytosis. Did you look it up?
Yeah, it's increase in platelets.
Increase in platelets. Close, right? But it's good. I like you guys guys, I'd like you to interact in the classroom, that's why I made you pull that out, I hope you don't mind.
What, an increase?
Yeah, I see it's increase.
This is an abnormal decrease in the number of platelets.
Yeah. Sorry. Thrombocytopenia.
Yeah.
Thrombocytopenia. All right, with bulimia, this is, gonna be, it's gonna be the binging. There's two types, purging and non-purging. Binging is when they eat a whole bunch of food at one time, over a short period of time. And then they do things to get rid of the food that are not normal, such as, purging, which, do you know what purging is?
Vomiting.
Vomiting, and non-purging. You know what that is?
Excessive exercise.
And use of, it might be,
Laxatives.
diuretics, enemas. Well, that would be under the purging. The purging is misuse of laxatives, diuretics, and enemas. The other one would be like fasting, and then, excessive exercise. And they're concerned with how they look at all times. So you need the recurrent binge eating. They're gonna do stuff to, lose weight by these behaviors. And like I said, the difference is, with the anorexic, you can have BMIs at as low as 17, 15. This, with the bulimic, they're gonna be either slightly under or slightly overweight. And they're always going to worry about their body weight and shape. After binging, they're gonna feel bad about themselves. A lot of times, they'll have other, instances of alcohol and drug abuse. And it could be related to the brain centers where it comes from, and that's with the binge eating. So you also may see enlarged parotid glands, especially with the vomiting, dehydration. You'll have electrolytes imbalances, but not as severe as the anorexic. Cardiac arrhythmias, EKG changes. For those who are vomiting, you might see esophageal tearing, and maybe bleeding and dental problems. So that is related to the vomiting, and all the acid coming up. Again, you'll have muscle irregularities, renal problems, problems with the blood sugar, weakness. There's a thing from vomiting that you might see on the back of the hand called the Russell sign, and that is from trying to self-induce vomiting. So with this, bulimia, eating will make the person feel better, but after they eat, they are going to feel bad about themselves, be depressed, and, be self-degradation and putting themselves down and feel really bad about themselves. And obesity. So obesity is not psychiatric, which we talked about, it's the binge eating. It is also, the binge eating is related to emotional, to feelings, feeling bad, feeling good. With obesity, it's going to lead to other health disorders. Did you get any disorders yet in 100 that you saw that obesity could lead to certain, like cardiac problems and stuff like that, hyperlipidemia? So usually you'll see the binge eating with the obesity. And again, that's eating more rapidly than normal. It'll be not feeling, they'll be uncomfortable after they're done eating, like overly full. They'll eat even when they're not hungry. They may even hide to eat because they're embarrassed. And again, they feel disgusted with themselves after eating or feel guilty for what they ate. So to get the diagnosis, it has to be present 1 day a week for at least 3 months with the binge eating. And it's not associated with the compensatory behaviors with the binging and purging, the binging, purging, or the non-purging. So here are some of the complications related to obesity. And I know you didn't get a lot of these yet. So, we know what high cholesterol is. Diabetes, do we know what diabetes is? I know you didn't get it in lecture, but osteoarthritis, angina, which is a chest pain disorder, shortness of breath, respiratory insufficiency, high blood pressure, heart disease, gallbladder disease, and bowel or rectal cancer. Any questions so far? No? All right. So when we look at the predisposing factors with anorexia and bulimia, years ago they said it was related to abuse in the family. However, they have moved from that theory. They look at genetics. If a sister or mother has it, then they might be more likely to have anorexia or bulimia. Usually it could be with a substance abuse or substance use or mood disorder. The neuroendocrine abnormalities, we talked about the hypothalamus, which regulates everything. So that could be a dysfunction in anorexia. Some of the neurochemical influences associated with bulimia could be related to serotonin and norepinephrine. A lot of times that's why you'll see them using an SSRI. And the binge eating disorder might be related to the reward pleasures. You didn't get addiction yet, but that's one of the things that is related to addiction in the brain. Also, brain imaging shows the orbital frontal cortex, which is associated with the reward and pleasure responses. And that you'll see in substance use disorders. We always have to go back to psychodynamic. So there's a problem in the mother-infant relationship, and it's a poor ego development and unfulfilled separation, individualization. And you might see, again, you might see some places about abuse, but I think that they have moved away from that. So you might see it even in controlling behaviors.
Could it be like a learned behavior as well? My mom did it, and I think it's normal.
Well, children pick up on a lot of things are learned. And I believe that, you think about how people grow up, and if my parents always focused on how they look and how I look when I get older, I might focus more on how I look. So, and you see that too with the learning theories and role models. And I think our culture usually, it used to be the thing, but it's also very about appearance. All right, so when we look at any eating disorder, we have to look at their history of eating, right? Any patient you have with these eating disorders, remember, they're gonna need a full history and physical, but focus now is going to be on the habits. What are they doing to diet? What are they doing to control their weight? Are they restricting calories? Are they purging? Are they exercising too much? And what is their viewpoint on weight and shape? How do they view it? Is it something that they put a lot of weight into, for lack of a better word? How are their relationships and social functioning? You have to look at the whole picture. Their family, their socialization. Are they impulsive? Are they gonna, with the binge eating, they might just eat and not even realize they're doing it. So a complete physical assessment is necessary. Do you know it's up there. The normal range for BMI is 20 to 24.9, and obesity is defined with BMI of 30 or greater, which I talked about. And anorexia, which we talked about, is a BMI of 17 or lower, but it could be down to 15 in extreme cases. So remember, we talked about the anorexic would have more interest in preparing the food as opposed to eating it. So that might take somebody like, a long time preparing this food, but then not even partaking in eating it. Terrified of gaining weight. See, these are the factors you need to think about when you're treating the person, because remember, these are the things that you're gonna have to work through. Because if they're afraid of gaining weight, it's going to be harder to, to get them to comply with therapy. See if they perceive themselves as severely overweight, especially when they are not overweight. Low self-esteem, and we'll get more into treatments in a minute. We're gonna talk about their self-esteem, if they're impulsive, if they have problems interacting with other people, if they need an intense physical regimen, especially with exercising, how they feel after eating, especially the binges, and sometimes there's obsessive compulsive features with some eating disorders, which I'll get into in a minute. So some of the nursing diagnoses we're gonna look at is imbalanced nutrition, less or more than body requirements, less for the anorexic, more for the binge eating, deficient fluid volume, if they are real fluid volume deficit or at risk for. Disturbed body image, like I said, they don't perceive themselves as what they are, they perceive themselves as being obese, and having low self-esteem. Anxiety, especially we talked about when they get anxious, gaining weight, denial. Some people don't even know they have a problem, right? And obesity. So with our outcomes, we want them to achieve or maintain at least 85% of their expected body weight. Remember, their vital signs are going to be abnormal. We talked about the hypotension. If they're dehydrated, they may present with tachycardia. And we want their lab studies to be within normal limits. We're going to be looking at electrolytes. We're going to look at kidney functions. We're going to look at, you didn't get LFTs yet, but if it affects the liver. You want them to be able to talk about adequate nutrition and how it is important. Especially if they're not getting enough and they may feel they are. And you want them to be able to verbalize the consequences of what happens from the laxative use and diuretic use and importance of adequate fluid intake. So if, what could happen with overuse of laxatives and what could happen with the overuse of diuretics? What happens to your blood pressure when you take a diuretic? I know you didn't get this, but it will drop your blood pressure, it will drop your fluid volume, and it could cause some electrolyte abnormalities. You want them to talk about what causes them to be anxious and demonstrate techniques for reducing it. So you're gonna, again, throughout my lectures, a lot of times it's giving them other coping mechanisms. You don't want them to be so occupied with the food. You want them to talk about ways in which he or she may gain more control of the environment. And remember I said, like, sometimes it's about control, so they want to feel control. And that's, when I learned all this, it was about abuse and control, but now they're moving, that was a little bit of time ago, a lot of years ago. And you want them to be able to verbalize their body being fat as a misconception, because that's how they perceive themselves. So you're going to use things to get them to see themselves in a different light, because if I tell you that you are not this, you're not going to believe me. So, you're going to use other ways, like numbers or measurements with tape measures. You want them to demonstrate abilities to control their lives without resorting to maladaptive eating behaviors. So this may be their way of coping. So we have to give them better coping strategies. Has established a pattern of eating for weight control and weight loss. And this is for somebody who is either, who has obesity. loss towards a desired goal and is progressing. It's progress. They're not supposed to lose 10 pounds overnight. And a lot of people go on fad diets hoping for that. You want them to verbalize plans for future maintenance of weight control. You know, with weight control, it's really important to start the conversation because there are gonna be plateaus in diets, and it really frustrates people. So you have to talk to them about like healthy weight loss, but also, you know, realistically, they're gonna be around social events with food. So what are they gonna do? Like put a plan in place. So, you know, when we talk about nursing care, it's, you know, with eating disorders, it's gonna restore, we want them to restore nutritional balance. It's, you know, we know that they don't have it because either they're not getting the calories they need or getting too many calories. And you want them to help them gain control without resorting to these eating behaviors. And self-esteem and positive self-image are promoted in ways that relate to other aspects other than appearance. What else is good about them? What are they doing? You know, what's positive about them other than how they look? You know, something, you know, maybe they're really good in math, maybe they're good on computers, like don't focus on, you know, looks. So in certain, hospitalization may be necessary in certain cases. Malnutrition, especially when it's 20% below expected height and weight. So they're recommended for inpatient, but 30% below expected height and weight is more long-term. If they're dehydrated, if they have severe electrolyte imbalance, so you may see, you remember the norms for your potassium level?
3 to 3.5.
So if they're below a certain number, they may be hospitalized because it could cause a cardiac arrhythmia. So if they're below 3.5, they might, you know, usually if they're low, they'll admit them to inpatient. And if there is EKG changes, they're gonna look at, you know, and you didn't get this yet, and I understand it. I'm not gonna say you have to look at, you know, a cardiac rhythm and decide the ST changes. You know, and the bradycardia, severe, so heart rate less than 50. Hypothermia, that temperature is 96.8. Hypotension, and it's usually less than 20 milligrams of mercury, less than, especially orthostatic. A 20 milligram mercury drop in when there's a positional change. And if they're suicidal, they need to be admitted. Any therapeutic relationship, you need to establish a trusting relationship in order for them to, and I think you went over this, we talked about this in anxiety, we probably talked about that in the beginning. You're gonna focus the conversation, do not focus on food and eating, because that's what they're coming in with. Daily weights and vitals immediately upon rising. This is very significant. You're gonna see changes, and you wanna make sure that they are accurate, so it has to be at the same time every day. You do not wanna just do it sporadically. A daily weight is the first weight when they wake up. Does that make sense? Because a lot of disorders, we require you to do that. Because if you change your weight during the middle of the day, if you had some food and drink, your weight's gonna be different. So you want first thing in the morning, every day at the same time, and vital signs immediately upon rising. Does that make sense?
On rising,
Do you
you
have
mean
any
from
questions?
a lying position?
Well, if they can stand on and on the same scale, thank you, that reminded me, because.
I'm just trying to figure out what the rising part is. Does that mean while they're in bed?
Waking up.
Okay.
It is me shortening my words. So when they wake up, you wanna get the weight, same clothes, same everything, same scale. How many here work in a hospital? Right, and you use a different scale, and it could be a difference of a lot, right? And there's a big difference between a bed scale and a standing scale. So if they can stand, get them to stand, same scale. Adherence to selected meal times. You want them to comply with eating meals So here's an important concept. You need to observe them during meals and for at least 30 minutes after. So what does that mean to me? I'm gonna stay with them while they're eating. Why? Why do you think that is?
Make sure they don't hide it or throw it away or flush it.
Yeah, exactly. So you have to watch them go to the bathroom. Because that's gonna be their natural instinct, because if they eat, it could cause them anxiety. So if I'm getting daily weights, I'm doing a daily INO. What does INO mean?
Input, intake, yeah.
Right, so, and a lot of times when they don't have, if like you see somebody who's malnourished, they might do that in the hospital anyway, and they do it with a lot of your patients. So we need to know what comes in is what's going out. So observe during meals and for at least 30 minutes. It could even be up to an hour. Because if somebody is used to purging, and even the anorexic, because they could purge too. So just remember to observe during meal times at least 30 minutes, up to an hour, daily eyes and nose, and watching them in the bathroom. So with the interventions, there's quite a few things. A positive approach, you know what I mean by that? Yeah, well, any client, if you feel you're gonna be judgmental, then you should ask somebody else to provide care. You should go in with a non-judgmental outlook if you can, and be positive. You want them to partake in their plan of care. If you have them, and even with the medical side, if they're part of it, then they may feel like they have a little bit of control over it. You want their input. You're gonna work with their family. Sometimes it's within the family that's the problem. So we're gonna incorporate the family in the plan of care. You know why we're working with a dietitian? Yeah, right, and they could work with them and the calories they need. And sometimes we wanna consider their preferences and the ability to consume food. Because remember, if they were purging, they might have some damage in their esophagus from all the acid. And they might need to have an NG tube for feeding. You know what an NG tube is?
Nasal
Yeah.
gas.
You wanna have structured and inflexible eating schedule and small frequent meals. You don't want them getting, if they eat a large meal, first of all, they might not be able to tolerate it because of the size of their stomach, but it also could cause bloating and gassy, so it'll be more tolerable, small frequent meals. And if they have esophageal issues, it might go a little bit easier. They might have to get a liquid supplement. When somebody, they usually go at a 25 mLs per hour. You have to start low and go slow. You want to prevent constipation, so you are gonna include fiber in their diet. You don't wanna feed them too fast, because I think you learned about this in 100, the refeeding syndrome, and it can cause electrolyte imbalances. Limit high fat and gassy foods initially. So you don't want them to feel bloated. You wanna prevent fluid retention, so you're gonna avoid sodium or low sodium. Most patients on a cardiac diet are low sodium, and that's to prevent holding on to fluid. You're gonna give them supplements. Remember, they're nutritionally not sound, so multivitamin and mineral supplements. And caffeine will increase energy, so sometimes with that energy increase, it could be difficult to control some of the behaviors. You know, you might wanna also work on meal planning, maybe a couple days worth of meal planning. So education is always gonna be based on whatever, disorder they have. You're gonna talk about, the symptoms and the effects that it has on their body. You could talk about the electrolytes, you could talk about, some of the, the calluses on their hands, you could talk about the effects on the esophagus, you could talk about, the more dangerous that it could, lead to cardiac arrest. You're also gonna talk about nutrition, ways and other ways that they may feel in control of their life. Do you remember your nutrition course? ATI is a really, little book about nutrition. It's really good to look at. Because we're not just this, everything, a lot of patients or clients that you're gonna be seeing will have to be on certain diets. And we'll talk about more, others, like, with somebody who's malnourished may lack thiamine and stuff like that. So it's really good to just review that just for your nutrition principles, because you have to teach it to your patients. I don't think anywhere you're at now has eating disorders, but there are centers that specifically deal with eating disorders. You want to have them express their fears and feelings and alternate coping strategies, which we talked about that with anxiety. And you know, when you also educate, you're also going to talk about medications, side effects for medications, also teach them relaxation techniques. We all know what they are, right? Okay. Problem solving skills. Instead of going to eat that half a gallon of ice cream, maybe talk to somebody before they do it or before they purge. With the obese patient, you're going to talk about reducing calories. Like I said, you want them to have a nutritious diet. There's 1,000 fad diets on it, not every out there. And they would have to be under doctor supervision for some of these diets. You want a realistic weight loss plan. It doesn't happen overnight, even though people want it to. Like, I think it's 2 to 3 pounds a week that, you know, you should ideally lose. And talk about physical activity. And remember, some of them, if they have some disorders, they need to do it through a physician. Because if they have cardiac disorders and they're, you know, jumping on the treadmill and their heart's going up real high, what's going to happen?
MI.
Yeah, it's going to affect their heart. Here's some of the support services that they have out there. Do you have that? Do you have that in your phone?
Yeah.
So when you're doing evaluation, you look at what, you know, what brought them in for treatment, and, you know, did they, you know, overcome them? So you would have to reevaluate what brought them for treatment, and had they made behavioral changes, the family and the patient. So I bring up the evaluation because these are like the keys where it's at, like, have they steadily gained 2 to 3 pounds per week, or at least 80% of the expected weight? You don't want them gaining too fast. One, it'll cause them anxiety, but also, you know, it's not healthy for them. Are they free of signs of malnutrition and dehydration? So you want to have like the good skin turgor, their hair, I know it doesn't happen overnight, but you know, what are signs of the poor nutrition? The hair, the skin,
Nails.
the nails, so things like that. Have they consumed inadequate calories as determined by the dietitian? Are they following, are they stashing food to discard later? Because this is where you need to watch them with their trays. Has there been any attempts to do self-induced vomiting? Have they admitted the problem exists, and are the eating behaviors maladaptive? You know, and, or manipulating the environment, are they still trying to do that? You want to talk to that, you want them to talk about what's really going on with them, because sometimes it can be related to, like I said, other disorders or something else that's going on in the family, sexuality or dependence or need for achievement. You know, and maybe these are related to control over their lives, and you want them to understand that, and that their perception of how they see themselves is not correct. For the ones with the binge eating and obesity, have they started a steady weight loss plan? Are they losing weight? You know, what about relapse prevention? You know, eventually they're gonna be exposed to, things that they may wanna eat that they can't. So again, focus on the positive and not size and appearance, but also focus on, what are their triggers? What's gonna trigger them to eat? Certain times if they're eating because they're anxious, they need to be aware of that and need to do a relaxation technique. You want them to see themselves, you want them to be able to perceive themselves for what they actually are. Sometimes people expect results, like I said, right away, so you want to let them, you want them to verbalize that they understand that their way of seeing themselves was unrealistic. And do they accept themselves as less than perfect? If they're comparing themselves to, what they appear is perfect and it doesn't relate to them. And coping strategies to deal with stress, other than eating. So some of the treatment modalities are related to cognitive behavior therapies. Now, cognitive is thinking, behavior is actions, right? So changing their way of thinking, cognitive reframing, using relaxation techniques, journal writing, desensitization exercises. If something's giving them anxiety, we learned about desensitization the other day.